Hello and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name is Mark Blunden. I'm a member of the RPTH editorial board. I work in Geneva, Switzerland in the division of angiology and hemostasis, and I have specific clinical and research interest in venous thromboembolism. Today, I'm very pleased to introduce Dr. Ian. Dr. Ian received her Doctor of Pharmacy from the University of Illinois and has been practicing for more than 10 years. She's recently obtained her PhD in pharmacy and health outcome research from the same institution and is currently interested in the social determinants of health in vulnerable patient populations, particularly patient access to timely and quality healthcare services. In line with this focus, she recently published an observational cohort study in RPTH looking at the association between transportation barriers and anticoagulation control among an inner city low-income population. Dr. Ian, I enjoyed reading your prospective cohort very much. Suboptimal anticoagulation is oftentimes thought of being related to comorbidities, diet, co-medication, and socioeconomic status. And I was very interested to see your exploration of various components of transportation barriers in the setting of your anticoagulation clinic in Chicago. Dr. Ian, we look forward to hearing your presentation.
Thank you, Dr. Blonder, for that introduction. And hello, everyone. My name is Connie Yang. I am very much excited today to be sharing with you some of my the research work that I have done in close collaboration with some of the clinical pharmacists here at the UIC Anti-Thrombosis Clinic. Definitely want to give a shout out and thanks to them for a lot of the work and contributions they contributed to this work. So really quick and diving straight into our presentation today, the reason why we went and explored this specific topic of understanding if there is any association between transportation and anticoagulation outcomes, specifically in patients with warfarin, is because there is this understanding that transportation is a major barrier for patients' timely access to medical care. And it has been identified as a social determinant of health when we take a look at the holistic medical care that is needed for patients to maintain good health outcomes. Kind of a conceptual framework that we had developed for this particular study is shown in the figure to the right here, which kind of lays out that different patient factors, their specific preference for mode of transportation can tie into the different types of transportation related barriers that can impact their ability to either make it to a clinic appointment or even access to a pharmacy to obtain their medications. And ultimately, these effects can accumulate to have a significant impact on patients' health since it can interrupt their care. They can subsequently to poor health outcomes. And what we have seen in the prior literature is that missed medical appointments has been linked to increased healthcare resource utilization, particularly of hospitalization or having admission to emergency room department. There was also one study that had noted that for patients who missed their appointments for kidney dialysis, there was an increased likelihood of premature mortality. Therefore, because of these outcomes that we have seen in other disease states, we want to explore, are we going to see similar complications in patients with warfarin control? And we focus specifically on patients on warfarin because of the fact that warfarin, as it's understood, has a very narrow therapeutic range. Therefore, it requires frequent monitoring and dose adjustments, and these typically require for the patient to come into the clinic to receive that specific care, therefore making warfarin management almost what we can call as a transportation sensitive treatment state. However, when we did a look into the literature and talk with clinicians anecdotally, we don't really understand, is there actually a true association between transportation barriers, whether it is vehicle access, cost of obtaining transportation, or other factors related to transportation barriers and its impact on patient-specific anticoagulation outcomes, which kind of led to our study here to really explore, is there a relationship between patients getting trouble getting transportation to clinic, or if they're having at least one transportation barrier identified, does that lead to either suboptimal or optimal anticoagulation control? So in order to explore this research, we conducted a prospective observational cohort study at a local urban academic healthcare system called the UI Health healthcare institution located here in Chicago, Illinois. We specifically approached patients who were over the age of 21 and were expected to be on long-term warfarin therapy for at least 6 months. These individuals had to have established care at our pharmacist-led antithrombosis clinic and had to have at minimum been on warfarin therapy for at least 3 months. So then we had an opportunity to collect baseline data for these individuals. Furthermore, this is an observational cohort study in which we obtained patient information long over the 6-month period from the time of enrollment. However, prior to that, we did want to pre-screen individuals to ensure that they met some of our inclusion criteria, specifically the long-term warfarin therapy. And then we also want to make sure we were able to contact patients. So we actually worked with the clinic staff to approach patients who met our eligibility criteria to see if they were interested in participating, and then consented and had them complete a one-time questionnaire and allowed us to observe their EMR data over a 6-month period. So in order to really kind of define what it means by transportation, and the reason for this is in the literature, the transportation has various different definitions. So we actually found that there was a modified version of Validate questionnaire that one of our co-authors had actually developed and validated. And using this questionnaire, we really defined our two main kind of exposures of interest here, which is, do patients have trouble getting transportation in clinic, and whether they have a cumulative score of more than one identified transportation barrier. Additional kind of exposures of interest we collected was the type of vehicle that patients took to get to clinic, and then patients self-reported travel time, travel cost, and then travel distance to see if any of these had an impact on their anticoagulation outcome. And how we defined anticoagulation control as either optimal or suboptimal was, again, abstracting patients' INRs from the EMR data over a 6-month follow-up period. We then defined, based off of using thresholds previously defined in the literature and from clinician input, a percent time in therapeutic range of less than 60% as suboptimal anticoagulation control, as again, based off of our understanding, anything less than this percent or this threshold indicated that patients were no longer receiving clinical benefits from warfarin therapy. To analyze and to really evaluate these associations between our transportation measure and anticoagulation control, we utilized log binomial models to generate prevalence ratios, and we did adjust these models for key kind of covariates that we had selected a priori, and through a modeling approach, and these included age, sex, and then annual household income. In total, were able to enroll 144 patients. However, after evaluating patient data, we had an analytic sample of 133. In this sample, on average, patients were about 60 years old. Primarily, we had a very much African-American or Black population, also primarily female. And unsurprisingly, because of the patient population that's typically seen at UI Health, majority of patients typically reported a household income of less than $25,000 per year. We also saw that for patients in our population, on average, they were on warfarin therapy for about 6 years overall. But looking at the standard deviation, we also note that because it's so wide, there is quite a large variation on the duration of time patients were on warfarin therapy. Now, when we compared some of these demographics to our UI Health patient population, we did see that these were very much reflective of the patients we see at UI Health. When we take a look at some of the key kind of outcomes from our transportation measure, we saw that about half of our population either drove themselves or had someone drive them to the clinic. And then about a quarter of our patients reported they took public transportation, such as bus or train. And what's interesting is that about 3% of patients reported they took either an Uber, Lyft, or taxi in order to get to clinic. When we take a look at the average kind of travel time patients report, on average, it was about 1 hour, about less than an hour, about 40 minutes for them to get to clinic. Average travel distance was about 7 miles, and then average self-reported travel cost was about $7 overall. While we did not see any significant kind of associations between these self-reported exposure points with our anticoagulation control outcome, we did note that patients who actually had suboptimal anticoagulation control did have about 2 times higher self-reported travel cost. When we took a look at our kind of key exposure of interest, we did see about a quarter of our patient population report that they did have trouble getting transportation to clinic. But despite this small number, when we took a look at the cumulative measure of the transportation barriers, about 65% of participants had at least one transportation barrier reported. The most common one of these was the fact that weather might have caused them to miss an appointment. And we also saw that travel cost also prevented, was another key kind of barrier that patients had identified with. In the results of regression models, we did see that participants who reported transportation trouble or had at least one transportation barrier were 1.6 and 1.68 times, respectively, more likely to have a suboptimal anticoagulation control. And I think this, again, really points, and I think it's one of the key takeaways, is that even though there may be different kind of constructs of how transportation is measured, we do see that even if patients report to a single item or cumulative 5 items of different kind of constructs of transportation, we are seeing this more suboptimal anticoagulation control. And I think it's very important to note is when we take a look at then perhaps what are avenues to perhaps mitigate these outcomes, is what I want to present here. So what we know is that there is a high financial burden for transportation. While in the United States, there are some healthcare insurances that may reimburse for non-emergency medical transportation or NEMT, oftentimes patients may still receive a copayment, or there may be tricky or difficulties in patients to actually request for these NEMT programs. We also know that a lot of healthcare systems in the US has implemented rideshare service programs with Uber or Lyft. However, there has been a lack of research demonstrating whether these rideshare services actually improve clinical benefits in patients who utilize these programs. Another avenue to consider is perhaps there's a need to switch patients who are suboptimally controlled on warfarin to direct oral anticoagulation agents such as DOACs. However, from what we know is that not all patients may be eligible for DOACs either because they have comorbidities such as kidney issues or perhaps extreme body weights, which may not make them ideal candidates. However, we also recognize for patients who may be candidates, there are still challenges such as high copayment or restricted insurance plan coverages, which requires patients and physicians to compile a series of paperwork to obtain prior authorization and may actually delay patients to timely access and initiation of these DOAC therapies. Another area worth exploring is if patients do have trouble getting to clinic, perhaps they can do self-testing or self-management of their INRs at home. And while there has been literature showing that patient self-management or self-monitoring of INRs at home has equal benefits as point of care testing in the clinics, these programs do require patients to have a pump or device at home to test these INRs, so requiring a device and also test strips. However, similar to the prior problems, there is also still a financial burden here, as not all medical centers in the US actually provides these devices for testing home INRs, and sometimes if they do, there is again this burdensome paperwork of prior authorization and a high out-of-pocket cost for these patients. However, this does not mean that these should not be options to be considered as similar to any type of medical care, there needs to be a very much personalized approach for healthcare services for patients. Before jumping into key takeaways, some limitations to note is that this study was a convenient sample of patients who were able to attend their regular scheduled clinic appointments. Therefore, we may not actually have been able to capture the full spectrum or may have underreported on some of the barriers for patients who actually weren't able to make it to clinic for us to sample from. There's also maybe limited generalizability as this is a single site study conducted here in UI Health. However, to our knowledge, this is one of the first studies to really evaluate, is there an impact of transportation on patients' health outcomes related to anticoagulation? And one of the strengths here is that we were able to utilize a validated transportation instrument to kind of sample across the different transportation constructs that I think previous studies had not been able to do. So what we want to take away from this is we see that there is definitely a strong association between transportation, whether it is out of a single item of transportation trouble or several identified transportation barriers that can lead to suboptimal anticoagulation control. And as we know, while transportation is not a medical condition, if we talk about the social determinants of care for patients and we take a look at want to provide care holistically to a patient, it may be important to consider the need to perhaps screen patients to see if they have transportation barriers and perhaps similar to precision medicine, offer appropriate resources or referrals to ensure we address these transportation needs for patients so that they're able to get timely access to the care they need and also receive the medical treatment and the access to medications that's going to ensure that not only are they adherent to medication, but also receiving the clinical benefit that was intended when they were started on warfarin therapy. That's all I have for today. Thank you very much, and I'm looking forward to the discussions.
Dr. Ian, thank you for this fantastic presentation. I really enjoyed it. So we have a few minutes for the discussion. I wanted to ask you first about a piece of data that was really puzzling to me. You stated that the self-report of transportation trouble getting to clinic was clearly associated with suboptimal anticoagulation, but actually self-reported time and self-reported distance from home to the clinic were not. How do you reconcile these findings?
Yep, that's a great question. I think in the literature, we see a lot of studies that have evaluated transportation. They take a look at travel distance and travel time. But I think from what we understand, there's a lot of complexity to these. For example, patients may have a long distance. They may have to travel 50 miles, but if they have access to a vehicle, it can be quite simple for them to get to clinic. However, for someone who perhaps needs to take public transportation, that 50 miles can be quite daunting. It can be a challenge because from what we know anecdotally, trains, buses, they don't always run on time, or they may be, for instance, from what we heard anecdotally from some patients, they didn't feel safe actually walking out to the bus stop and waiting for the bus to get to them. So that kind of plays into a little bit as to perhaps why we don't see direct associations, because we can't just just use travel distance and travel time alone. We need to contextualize that data to the kind of environment that the patient may be in. Is another example would be patients may have only to walk a block to their clinic. It's quite short, just a block. However, if you consider the patient uses a cane, the pavement getting to clinic is very uneven. That one block can again be a detrimental barrier for that patient from getting a clinic. So even though it could be a quick 5-minute walk for someone who's healthy, it take 20 more minutes for a patient who has physical challenges to get there. So I think that kind of plays into why perhaps we don't see any clear association, but I think it doesn't mean we shouldn't continue evaluating that data when we talk about transportation overall.
Thank you. So you suggested that we should screen actually for transportation barriers within clinical practice. How do you actually do it in clinical practice?
Yep, and that's a great question as well, is I think what we want to know is like, okay, we know this is association, so the next steps, right? From what we've seen, at least in our data, even a simple one-item question of asking patients, do you have trouble getting transportation to clinic, show that there was associations with suboptimal control of warfarin, right? So perhaps that could be as simple as, while we screen patients for their vitamin K diet, we're screening them for alcohol use and other kind of dietary and kind of social economic statuses at the clinic. Perhaps we can also tie into the workflow of adding a simple item to not only just see yes, no, do they have issue, and if they do say yes, depending on the institution, to see if then there are resources to really refer patients to get the type of care they would need to address their transportation issues.
Thank you. I wanted to ask you a more methodological question. In your publication, you stated reverse causality as a possible explanation for your finding. Could you explain to me and to the audience what this is, and specifically in your study, how this could have occurred?
Yes, sorry. Let me see here. One moment, is I think it helps if I share this image to kind of, I'm a very visual person, so it kind of helps. So in our analysis, what we saw or we evaluated was transportation as an exposure to leading to the event of interest, which is the anticoagulation control over its suboptimal or optimal. However, when we kind of think about this conceptually, what we know is that patients who are suboptimally controlled on warfarin therapy are going to require more frequent trips to the clinic in order for that monitoring and dose adjustments. So we increase the number of visits due to the fact of the level of the anticoagulation control. This essentially ties into would probably lead to the patient having a higher likelihood of having transportation issues then. So when we say reverse causality, it's essentially we're switching the outcome and exposure. So in these instances, the anticoagulation status of being suboptimally controlled becomes our exposure, and then our outcome becomes whether the patient has transportation barriers or transportation trouble. So that's kind of what we mean by the reverse causality, and I think that's something worth exploring in the future is that a true causality? Is it possible that the increased number of clinic visits for patients who are suboptimally controlled doing this reverse causality effects? And if it is, does that mean we need to develop different levels of care for patients who are suboptimally controlled as opposed to having these more frequent visits? Is there something else clinically that we can do either at a one-time clinic visit or perhaps through a lot of the work now through telemedicine to help patients manage their control in a way that it's not going to cause actually these transportation issues for patients? Does that kind of answer your question?
Yes, that was very clear, and thanks for providing the slide. I think that helped a lot. And I have a last question. I had the chance some time ago to spend some months of winter in Chicago, and I remember the cold temperatures, the wind, and the snow. Have you explored whether season was associated with either greater transportation measures or lower TTR in your sample? Or if not, do you hypothesize that this could be the case?
Yep. Great question. I think that was something we were also interested in exploring, but due to the study period, which only really covered for some patients summer and fall, or for others fall and winter, we weren't really able to get a good adequate sample to explore the effects of seasonality. Because what we saw, and again in our sample, is that patients did report that weather was a barrier for them to get to clinic. And I think from what I've seen in the literature previously, was that there has been studies that shown either extreme heat or extreme cold situations, or in some countries where there are monsoon seasons, that can be a factor that contributes to either missed appointments, rescheduled, or just having a lot of complication for patient to get to clinic. So I think if we had the opportunity to explore really for our Chicago population, does winter time or summer times where we have the extreme heat, extreme cold, and increase the likelihood of missed appointments or the increase the likelihood of patient having to reschedule, I think that would be valuable information for clinic staff to know. So then perhaps there are methods to work around. Well, we can't control the weather, unfortunately. That's something outside of our control. But we can work around it either perhaps in the winter, summer months, we can do home health visits, right, for the home INR test, or if there are methodologies to perhaps utilize the use of telemedicine to counsel patients on their under control, or perhaps this really ties into need perhaps to have conversations with payers to say, there is this identified need that we need patients to test their INRs at home because of the fact that they're having trouble getting to clinic. I think as we know in this COVID situation, patients, it's tricky for patients at the clinics as well. So there needs to be different avenues explored perhaps outside of transportation to ensure patients are getting the access to that care that they need.
Well, thank you very much, Dr. Ian, for presenting your work and giving us more insight into the complex topic of transportation trouble and transportation barriers for patients within anticoagulation centers. We hope viewers will read the full detail of your paper on our site. And Dr. Ian, I hope you will publish again in RPTH. Thank you all for watching, and keep an eye out for the next RPTH recap. Stay safe.